I took a very clinical view on this question, therapeutic aims of the oncologist between cancer control and quality of life. And I think many of you are in this situation to talk to the patients and make informed decision on to go for treatment or to withhold treatment or to meet again on another occasion to rediscuss. And yeah, I wanted to share my thoughts on this, and I wanted to start with a gist. And some of you might know that I have also an interest in GIST. So this is a patient I followed for very, very long, and she had extremely low risk GIST and was resected in 1998. And so actually you would expect that she is cured. But here you see how individual the evolution of these cases can go. And then we see this in daily clinic. She had a relapse 5 years later. In a way, it's unexpected. With multiple liver mets, unresectable. Obviously, we started here on a TKI, imatinib. That went quite smooth. The problem is, again, that these patients continue to progress. So this is the PET scan, and you see here, this progression. We treated her, nice response on the PET on the sunitinib. So this went on. And but unfortunately, then later you see again progression and the need to switch again treatment. So obviously, we were happy about the results with imatinib first, and we were happy about the results of sunitinib. But what does the patient say on this? Yeah, and it's only when I prepared these data in 2008 for this meeting that I have asked myself, but what have I done? So this patient had polyneuropathy grade 3, diarrhea under Imodium grade 2, hypertension, which I had to treat with a triple therapy, 7 kilos weight gain because of edema, had ulcers of the lower legs, had hand-foot syndrome, was tired, had urticaria for which I gave her cetirizine, and she has pain which were opioid dependent. So it was the first time that I realized all this because it was condensed for this meeting slide, and I was reviewing and saying, oh my God, what have I done all those years with this patient? But I mean, believe me, we had this discussion so often that I said, hey, shouldn't we stop? Shouldn't we reduce the dose? What is your thoughts on this? And this patient always replied to me. She said, Dr. Montemurro, I need to live. I want to live. I have my grandchildren. I want to see them as long as possible. And so we carried on, yeah, and we reduced the dose on one occasion. I added some pain medication. You see all this. But this is really for me when Giuliano invited me to share my thoughts on this, and this was the patient who came immediately to my mind. I mean, obviously survival is something, but quality of life is something else, and bringing these two together in an individual patient is very important. And yeah, this is a very brave lady. She tolerated a lot because she had a goal. But in other patients, this might not work out. So this is really something very, very individual. And we struggle to balance this in an individual patient. There is very little data. And let me expand a bit on this. So yeah, this is the ulcers, the edema of this patient. And yeah, then she had again progression. We switched treatment to this time sorafenib. You see, this was the progression, again, a response. But under sorafenib, she had like this very weird dermatological rash. You know, this is like, it was circular completely around the leg, appeared spontaneously, disappeared spontaneously. and all these funny things. So this in one patient, so many different toxicities. Yeah, and now this was the introduction. One patient on a TKI, and what we need to discuss. So what we need to discuss is the oncology goals of the treatments. Obviously, we as oncologists or gastroenterologists, we want to improve the overall survival or the progression-free survival. We might have other goals like organ preservation, and but we also need to have in balance, in check, the quality of life and toxicity. And this is a slide I borrowed from a presentation I had on rectal cancer. And obviously here you see there's also the function which comes into play. Good sphincter function, genitourinary function, and obviously the neurotoxicity from the treatment. Yeah. And some of you might know, and I just wanted to tell this, we have now in rectal cancer, for example, to balance intensification of chemo with a dual goal of organ preservation, sphincter preservation, which is very important for the patient, or to improve resectability and increase outcome. Yeah. So this is something it's very tricky to decide on occasion. Yeah. So this I showed you. Wait, sorry. Yeah. And we struggle to put the patient preferences into a hierarchy. And in different populations, the hierarchy is different. And what is certainly clear that the preferences of the patient and the physician do not overlap, or at least the hierarchy is different. Yeah? Many patients say, obviously, they want to be kept alive. They want to maintain independence.
Everything is open now.
And they want to reduce the symptoms. To put this in another context, there is this tool of the ESMO, the Magnitude of Clinical Benefit Scale, which on some aspects helps, but it's not including the views of the patient. So obviously, I think it's useful to have this to get an idea from kind of an survival response rate, yes, and maybe also reimbursement. You have a good idea with that, but it still does not include the patient preferences. And if we look into patient preferences and what happens to the patient, there comes a new tool into play, which is patient-reported outcomes. And this is a slide from Celia Diaz, which she showed at ESMO. I mean, there's a lot of things to consider for a patient. Yeah, it's like physical well-being, and there's different aspects which are touched and influence this. There is emotional well-being, which is obviously there's a lot of sub-aspects. Social issues are really important. Sexuality, I mean, obviously is in the younger population, but I mean in everyone is important. Practical things, cognitive function disturbances with any treatment are also not to underestimate. Yeah? So the picture, so moving from just overall survival, progression-free survival response rate to kind of quality of lives, to all these aspects which you see on this quite busy slide, the picture becomes more complex. Yeah? And let me now drill down on different aspects to consider. Yeah, to balancing cure and survival effect. So obviously, to consider is the different toxicities which someone can experiment during treatment and can also suffer from as a survivor. And I will scan through this. So, I mean, obviously neurotoxicity with the standard treatments is of a big concern, and with some of the TKIs. And this can last. And I think it's very troublesome if you have a cancer survivor who cannot pursue his activity. Like imagine like a violinist who has lost the sensitivity in his playing hands. It's terrible. Or someone who has pain and can't sleep because of the plus symptoms of the neurotoxicity. So I think this is really something to follow up and to put into the balance with the patient preferences and work and whatever the patient is doing. Yeah, this is options to treat. Obviously, dermatological toxicity is very frequent with the modern treatment to be looked after. Bone health is less a concern with the TKI and the immune therapy, more with the chemotherapy, but it's also of importance. And this clearly with the TKI is the cancer-related fatigue and the treatment-associated fatigue. It's something we as a physician, we probably underestimate, but maybe any one of you can relate to the last viral infection where you were not doing so well.
And this mood now is on.
And how much rest you needed. And this is what our patients then experience all along. Yeah. Of particular concern, and I mean, obviously in our focus is the cardiac toxicity. We are all familiar with the cardiac toxicity with the standard drugs, but it's also with the TKI. And recently, we have also learned that depending on the baseline risk, there is also considerable cardiotoxicity with the immune checkpoint inhibitors. So this is something to be watched out. I mean, if you look in this, even if it's 1%, the number of patients treated is high. So the number of, I mean, the absolute number of patients who suffer then from this is considerable. And this is a burden to the, I mean, obviously to the patient, but also to the health system, and something I think we need to get more aware of. The list of the toxicities which you can experience with the immune checkpoint inhibitors is very long. Yeah, so it basically can affect every organ system, which makes it so complex, because obviously if you want to, in a given consultation, which is 30 minutes, you can't perform for any of these items like checklists. So you need a bit to rely on your experience, on what the patient tells you, to get a quick overview. Is everything okay? Then you can move on, or to identify where you need to look more closely into. Yeah. And it's quite complex because it's clinical, it's imaging, it's lab, and you have to bring all this together. Yeah, you have understood I have an interest in cognitive dysfunctions, so I can't highlight this enough. Patients suffer a lot from this. If they can't remember things, it's very annoying to them, and their performance is less. They have less concentration. The short-term memory is less, and this is very, very poor for the patients. And the family around often does not understand this. So one step is also to include the family in the consultation and say, hey, there is a problem. This is not an unwillingness of your dearest. It's really, that is the result of the treatment. And this can happen with TKI. You can have also, let me move into this, can also have like personality changes. So something we really need to look for. Coming close to the end, a population which obviously makes the majority of our patients is the elderly. So there are some specific considerations in the elderly patients. So first, organ function is different. So this leads to a number of changes. Could be increased toxicity, but also decreased absorption. All this, it's very individual. But most importantly, one elderly patient is not like the other. And I have this slide from a dear colleague and friend of mine, Dr. Dosa. And I think these two slides express very nicely the difference between a patient of a given same age, right? I mean, you see the Pope on your left. He's super fit, and and other patients can be very, very poor in shape, right? And this is same chronological age, but very different biological age and function, and this is very important to consider. And I think many of us, we don't use formal tools to assess this in geriatric patients. I think it's also not necessary for patients which are fit, where you think, okay, this patient comes in, no medication. Last weekend he was 3,000 meters hike, so everything's fine. But and on the other side of the spectrum, you see a patient who is really not well off, poor performance score, lying in bed all day, already not eating, already not drinking, with any given dementia and other complex comorbidities, then you might say, okay, the fit patient goes to treatment, the frail comorbid patient does not receive patient. But there are some patients in between where starting with a limited screening like G8 score, if you're familiar with this is very fast. I have introduced this into my clinic. There's apps to doing this. This is very, very quick. And if the G8 shows you some problems, then you might look more into details, even you yourself, or with the help of a geriatrician. It's very helpful then to discuss things together, because some problems might have been, some problems you might address, and then you can move to treatment, or you say, this is not useful for this given patient, and then you don't administer treatment at all. And you have this formalized, so you have something you can, it's an objective measure. It's no longer your personal feeling of anything, which is sometimes misleading. Yeah, and then there's other apps which evaluate frailty, taking in consideration a bit the functional situation of a patient. So, having said that, it's a combination in balancing this. It's a combination between oncologic outcomes, quality of life of the patient, preferences of the patient, and also the emotionality of the patient. How does he feel? And patients, everything can be fine, like patient is cured, not so much toxicity, no long-term toxicity, but he can still be distressed for whatever reason. Yeah. So some use this distress thermometer. This is handed out to the patient, and you ask just to tick, and so you know where does your patient stand? Is he stressed, less stressed? And sometimes it's good just to know, hey, patient patient signals he's in distress, and you say, why are you worried? Yeah, everything looks fine to me. And the patient says, yeah, you know, I don't know, I have work issues, and something. Maybe just by talking about this, you can improve the oncological communication and help your patient. And some items might just need also like help. Many of you will have social assistants which can then talk, review the workplace situation, and so forth. I mean, you are familiar with this, I think, and keep this in mind. I think it's helpful to know, is a patient in distress or not, because everything else can run smooth, and still you have the impression something is wrong, and this might just because of that. So decision making is complex, and in this map you have all the items we consider as physicians. Yeah, I won't read them out for you, but I think what is really key in making a decision to treat a patient or not is to learn the patient preferences, his convictions or her convictions, and maybe also profound beliefs, like they could cultural beliefs, religious beliefs, and really to get a good grasp of all of this. And if I might say, it's not only the patient, but also the relatives, because the patient might want this, and the partner might want that, and the children of the patient or other relatives might want something different. And you have to bring this together, else this will not be a successful decision-making process, not a successful medical consultation, and this will also impact the outcome of this patient journey. Yeah? And I think what's really important in balancing this, so cancer control and quality of life, which was the question of my talk, I think there's one thing I can say: communication is key. And as a rule of thumb, probably many or all of you, we do it all, treat your patient as you would treat your mother or your dad. Yeah. Thanks a lot.
Thank you, Michael, for this very, very, very exciting contribution. And you have shown that how complicated is life. Not only decision making is complicated, but also life itself. And it was very, very nice to see all the different aspects you put into your presentation. And my question first is that quality of life is very difficult to measure itself also. What do we think about the integration of maybe SF-36 for a score, for example, in a conditioned way in the decision making?
Yeah, dear Guido, thanks for this comment and this question. Coming back to your question, do questionnaires or certain questionnaires help in this? I think probably yes. The problem is two things. It's super time consuming, and I mean the consultations get always more and more packed. So this is one thing, and the other thing is that we don't know, or we know less. So if we go on a longitudinal evaluation, what is a meaningful change in the quality of life? So someone starts setting a level 10, is then 12 really better, or is 8 really poorer? Yeah, and this is something where it's difficult to say. So stable, we always assume it's good, but how much do we need to improve to have a meaningful impact in quality of life, and how much do we need to reduce? And I think, and some of you might have seen this, there's apps coming into the consultation where the patient ticks himself the items, and so you improve on the time aspect, and the patient has also all the time to fill this out. He feels not stressed, there's no one supervising him, and then you get many data points. And I think over time this will help us then to really understand, with the capacity of analyze all these data, where we need to improve and what becomes really important. Today, I totally agree. If in doubt, I think scales and questionnaires are important and give us a more detailed view of the patient interior, and remove us from our just like feeling and say, yeah, everything is fine, while it's just not. So yeah, I'm not sure if I answered the question completely. I think intuition is good, but sometimes you need to drill down, and the questionnaire is helpful for that.
Okay, thank you for your opinion. Yes, are there other questions around?
I have a short question. We started with the definition of the maximum tolerated doses. At the beginning, it was, everything, because we thought about to cure the tumor. But we now know that we don't cure. In most of the cases, we don't cure the tumor. So we could maybe slow down and say we accept that we don't cure the tumor, but we give, you know, less therapy, lesser dose, and the patient has to, you know, to treat the tumor, to consider the tumor as a chronic disease, as you know, we met by treating GIST, and this is in most of the cases a chronic disease. My question is goal of treatment. This is really a true question. You know, cure, you may want consider to eliminate this term, curing cancer, but you know, accept that you don't cure it, but you stop growing, the growth.
Giuliano, great comment and great question. Let me complicate this further. I mean, we know now that therapeutic drug levels can vary so dramatically between individual patients that probably the concept of one dosage fits all and body surface area is probably not correct. I mean, looking at the classics, the 5FU is probably underdosed in 1/3 to half of the patients with the standard dosing for imatinib. We and others have evaluated this, that plasma trough level correlate with probably outcome and toxicity also. And let me add, there's a colleague from Lausanne, Bertrand Rochard, who has investigated this. It's even complicated because so the blood levels might not reflect the intracellular, so the intratumoral drug levels, which can also vary by factor 10 or so. So it's really complicated. I think this one size fits all and body surface area, we use it because we have no better mean, but I think we know it's distant from perfect.